Good morning. Can you hear me?
Yes.
This is not working. Thanks for coming. And I think the crowd was a bit smaller last year, and it's good to know that it's increasing in size. We are primarily focusing on patients who already have myeloma, but if you have any questions on patients, on how to detect early or how to pick it up when you're not having any symptoms, there's one slide at the end, but we can talk about it later when you have a Q&A session. But if you've got any questions, please do note somewhere and we can talk about it later. So just to go to the basics, myeloma is cancer of the bone marrow plasma cells and is not something that is generally treatable with the chemotherapy options and the treatments that we currently have. But there's been a lot of improvement, and that's why we are all here. And we've heard that some people are here, they've been here since 2006 and even before that. So the first statement should not be taken as a bad sign at all. So most of the times it's seen inside the bone marrow, but in many cases it can spread outside the bone marrow, and in such cases it's sometimes called plasmacytoma, which just means that it's a collection of plasma cells outside the bone marrow. The median age of residation is about 65 years worldwide, and we don't think we are any different here in Singapore. The incidence among Asians in Western world is about 45 per 100,000. But we may be slightly lower in incidence in Singapore, but we don't have the exact statistics of that. The pickup rate has been going up over the many years in the Western world, and this might be because there will be more reporting of myeloma, more awareness among the doctors. So it seems like the incidence has been going up, but part of it might be because of increased detection. But it could also be other factors which we don't know, real patient factors where myeloma is increasing in incidence. And the final thing is that males are more affected than females. So what is myeloma? Before that, let's just go to how myeloma starts in most patients. So in most patients, there is a very complicated word right at the top. Okay, it's called monoclonal gammopathy of unknown significance. It's a mouthful, but you can call it MGUS. And it's a condition where the body has started going slightly wrong, and then the plasma cells have developed mechanism of growing out of control. But it's nowhere near being a trouble. So this is the early stage, and most patients of myeloma would start up as MGUS or a pre-myeloma stage in most patients. So there would be a phase during which time patient would be normally no symptom, without a symptom. From there, patient go into a phase called smoldering myeloma. Smoldering myeloma is where it's smoldering, or something like it's started to burn, but you're not feeling the heat yet. Okay, and then the final phase is called myeloma itself, where you really have all the symptoms of myeloma and all the problems from myeloma. So the issue is whether we can, we do find out many times patients being picked up in the early phases of MGUS and smoldering myeloma, but most of the times patients come when they have myeloma. That's when doctors and patients have, they find the symptoms overwhelming that they come to doctors. And for the doctors it's easy to pick up because there are visible things in the blood if they look for it. So what is myeloma? What is active myeloma? Active myeloma is when the plasma cells in the bone, which have gone out of control, start to affect your normal organs. So in the early phases, which is MGUS or smoldering myeloma, they don't do that. So whenever the plasma cells start to attack your normal organs, that is myeloma. And it has got no connection to the amount of plasma cells in the bone marrow, or even the M band we call all the time, it's got no connection. Even if there is an M band, if you see these things, we're convinced that it's because of the plasma cell problem, we still call it myeloma. So, as I mentioned, on the left side you see here, these cells are plasma cells, and these are the abnormal cells. And what you see in the blood is, you can see there's a spike. This is electrophoresis, which is basically we just run the blood on a strip and look for the various bands of globulin and albumin and globulin. You see this band is abnormal. This is called paraprotein, the second band here. This should not be seen in normal people. And when they start eating the bone and make them weak, you'll see that the skull, this is skull for example, is, there are holes in it because the skull is weakened. The same thing can affect the hip bones, you can see the holes in it. And the same thing happening to spine, you can get back pain and sometimes even nerve problems because of that. And it can cause collapse of vertebrae, and that's why the pain happens. So, as I mentioned before, it's the pre-myeloma phase that may not progress to myeloma in many patients. So the progression rate is about 1% per year. So for example, if somebody is 60 years old, the chance of developing myeloma by the time they are 80 is about 20%. So it's 1% per year. And the incidence is about, in people about 50 is about 3 to 4%. And it will not be picked up unless special tests are done. And most times it's not done because people don't have a reason to go and see a doctor. And at this stage, even if we find out that the patient has MGUS, there is no treatment generally. So when it becomes smoldering myeloma, the difference between smoldering myeloma and myeloma is just based on whether there's any end organ damage. Okay, so if we have no organ damage, it's smoldering myeloma. But if there is organ damage, it becomes myeloma. So the organ damage is, it's a picture here to show that it can cause bone problems, not just skull. It can, your limb bones, your leg bones. It could be your pelvis. It could be any of the bones. And these proteins affect the kidneys, and it can cause kidney problem. It's also because the bones, when they get thinned by the myeloma, calcium is released from the bones, and this go and can deposit in the kidneys and cause a problem. The protein itself can deposit in the kidneys, can cause problem. And sometimes patients have pain, they take painkillers, and some of the painkillers can affect the kidneys as well. So it's many things, and sometimes they don't drink enough water. So it's a combination of many things like dehydration, painkillers, bone problem, and the protein itself causing kidney damage in myeloma. So very important that if you're on treatment for anything, especially medicines and all that, it's very important that you're hydrating yourself all the time, at least 2 liters of water every day, especially in Singapore when it's very hot. You can have little spots on the skin, which is because of low platelets. Sometimes there could be a bleeding problem also, so these things can happen. And as I mentioned earlier, there's a band of protein at the end, right at the end, which we see in the blood. And this is the abnormal protein that we use for testing and finding out. So just to recap on the definition, MGUS is when you just have a problem in the blood, but nothing to worry about. It's not going to progress to myeloma in many patients. Smoldering myeloma is when we know that it's going to be myeloma at some point, but not there yet, and probably don't need treatment. Some patients may need treatment in smoldering myeloma. That depends on the patient's other factors. In myeloma, surely you need treatment. And we call it CRAP. End organ damage is given a pet name called CRAP. C stands for high calcium, which because the bones are weakened and the bone, calcium is coming out. R stands for kidney problem, renal. A stands for anemia, which means that when the myeloma is affecting the bone, there is not enough space for normal blood cells to grow, and there can be anemia. There are other reasons why there is anemia in myeloma, but the most easy comparison would be when the factory is still no space, there isn't enough for production. And then finally, bone lesions. That's because all the myeloma eat the bone and make it thick. So staging, unlike the other malignancies like cancer, there is no staging where stage 1 is in one part and stage 4 is when the rest of the body is affected. It doesn't happen like that. Staging in myeloma is purely based on 2 things right now. Although this is not perfect, this is the best we have right now. It's purely based on 2 things: a blood test called beta-2 microglobulin and another test called albumin. Albumin stands for how good your body is coping with myeloma. So generally, albumin is a good marker for nutrition and the body's wellness. So when you're not having good nutrition, when your general health is poor, your albumin goes down. This is not just in myeloma, in also other conditions. So this is a surrogate marker for how good your body is. And beta-2 microglobulin is a marker for how active the myeloma is. So it's very simple. You're just looking at the tumor load, which is a beta-2 microglobulin. Albumin, which is to see how good your body is. So based on these two, we have got 3 stages. This is done at the time of myeloma diagnosis. It's generally not done later on. It doesn't have any validity later on. So when the patient comes for the first time, where they are either stage 1, stage 2, or stage 3. It doesn't really have a bearing later on when they realize, what stage they are. The reason why this is important is because this is a study that tested this, and you can see that there's a big difference if you look at any particular time point, you can see that the median survival is clearly different between 3 stages. So in stage 1, this is before the new medicines came around, the median survival was 62 months, right down to 29 months in people with stage 3 disease. Okay, the risk stratification, Professor will discuss in detail. I'm just going to have this one slide. So based on the chromosome study, which is very important, there is a breakdown as to good risk, or standard risk, intermediate risk, and poor risk. There is still more work going on at the moment on all this. So this is not the final list at all. But what we know that certain things, certain chromosome changes are associated with early chance of relapse and difficulty to control disease, notably 17p deletion. Whereas certain others called hyperdiploidy are generally related to good response to treatment and long-standing response. So we do use this a lot in sometimes deciding what's the risk of patient relapsing, etc. We don't really use this to decide what treatment to give right now, because we know that all the treatments right now are good for generally all 3, although there is further refinement needed. So other factors that might decide treatment include, how old they are, because generally if they are above 65, not by number, but physiologically, that is very important. So if you're a young 70, it's still no reason not for having a transplant. But if you're old, say 60, it's still a problem. So it's about how well your organs are, your lungs, your kidneys, your bone, your heart. This is what matters when you come to transplant. So it's not how by number, young or old you are. The chromosome study results, as I mentioned earlier. Other problems like diabetes, kidney failure, which may be present in many patients. In fact, diabetes can be quite common. It's very common anyway. And many of our myeloma patients do have kidney problems. So all this have a bearing on how we treat somebody with myeloma. So very simplistically, when you have a new patient, the first thing we think about is whether they are for transplant or not for transplant. And as mentioned, this age is, again, physiological age. And if they are not, then they are not for the transplant. So if they are for transplant, the first thing is, they have something called induction chemotherapy, which is where we give a combination of 2 or 3 medicines. And the aim of it would be to bring down the myeloma bulk as soon as possible. And after 3 to 4 cycles of chemotherapy, we would aim for stem cell collection. Generally, stem cell collection is done early because there is some worry that if you do many cycles before, the collection yield, stem cell collection yield might be poor. So increasingly, we try to collect, regardless of response, after the first 3 to 4 cycles. After that, we can still give more chemotherapy if you want to improve the response before transplant. So the stem cells collected will be frozen and stored. And then after giving more treatment, when we think that the patient is ready for transplant, that is after a satisfactory response, you consider bone marrow transplant. Bone marrow transplant is basically, what we use right now is something called high-dose melphalan. Melphalan is a very good treatment for myeloma. It's also a treatment in a way it kills the stem cells. So we are thinking, the theory is that myeloma stem cells, there are cancer stem cells. They have not been proven conclusively, but we believe that there are some stem cells which are driving the whole thing. So you've got a drivers in the bottom, the mother cells, and the baby cells are myeloma cells. So we're thinking that by using cells, cells which can kill the driver mother cells, we can clear myeloma. Clearly wrong, because we still have myeloma coming back after using high-dose melphalan. So it's no way, 100% foolproof. Yet it's better than what we had before, especially with the newer treatment. Melphalan is still the standard treatment. So you have transplant, you stay in hospital for about 4 weeks when you have all the side effects. Then slowly the counts start to come up, you feel better, and then you get discharged. And after that, the option is either you have maintenance, which is have some treatment for the next few 1 or 2 years, or if you had enough, you just say, I don't want any treatment, can I also? So sometimes these decisions are based on how bad your myeloma is. Some people have bad myeloma by chromosome study, so we think that there might be benefit in continuing treatment. Some people may not have gone into a good response, so we may have to continue treatment. But this is something that we can discuss, and it's not a clear yes or no, and it's something that we have to discuss with patients. And then, if you relapse later, retreatment. So again, treatment is going to be discussed by Dr. Tan later on, but the standard is that we combine conventional treatment, which, for example, say cyclophosphamide, with steroid. Steroid is very important in treating myeloma, and that's also the reason why people have diabetes worsening during chemotherapy, with novel therapy. Novel therapy are not chemotherapy. They specifically affect plasma cells in such a way that normal cells are not affected. Chemotherapy are different in that it kills normal cells and abnormal cells alike, which cannot help. Whereas things like bortezomib and lenalidomide are specifically targeting abnormal cells only. So we can limit toxicity and also improve the targeting by using this novel treatments. So there are some examples there. You may have heard the names. We call them by pet names: VTD, VRD, VCD, CyBOD, all sorts of names. Along with that, it's very important that all the supporting medicines are given, which include aspirin, acyclovir, which is to prevent virus infection, some medicines to prevent chest infection, and injections to protect your bone because myeloma does weaken your bones. So these are the things that go with them. So if you are transplant ineligible, you are still good for getting all the nice treatments except for no transplant. So being transplant ineligible doesn't make any difference, except for the fact that there is no transplant. So all the newer medicines and everything that is applicable here as well. Normally you have an induction or treatment as it is, and then issues whether you have maintenance or retreatment when it relapses. So complications that may happen during treatment and after treatment. Infections, because it weakens your immunity. We give treatment which makes it even worse. Fractures can happen because of weak bones. Kidney problems, as I mentioned. Another major problem is numbness of your hands and feet because of side effects from chemo. Many patients have diabetes, for example, so that can already have an effect. So it's a combination. It's very important that these things are picked up early, because once the numbness becomes pain, then it's very hard to reverse it. There will be only minimal improvement. So sometimes it gets even worse and becomes debilitating. So no mobility. So these things should be prevented right at the beginning. So we had a lot of side effects from newer treatment, especially newer treatment, with numbness and all that in the beginning, and we were not very good at recognizing it early and stopping the treatment or modifying treatment. So you will find that many patients from the early years had a lot of side effects which went out of control. But we are getting wise now, and we advise, we are looking for side effects very early and proactively think about cutting down the dose or changing treatment so that long-standing damage does not happen. Constipation is a problem because of the treatment side effects, and also the fact that sometimes you may not walk around very well because of pain, and you sit down and the mobility of the gut goes down. So it's very important that you hydrate those as well. Blood clot is another problem. Again, multifactorial. Many patients are above 65. Increasing age increases the risk of blood clot generally. Okay? If you're bedbound, increases the risk further. If you're not drinking well, another reason. The treatment that we use also increases risk. So there's a very, compared to normal people, high risk of developing blood clot. Luckily in Singapore, or even in Asian population, the risk of blood clot is a lot lower than Western population. So the projected data from Western population is higher than what we have in Singapore. Again, probably because our genetic makeup is in our favor. So that's something which is probably in our favor. Worsening of diabetes is another problem, because again we take medicines which can steroid, which is part and parcel of myeloma treatment, can increase your blood sugar level. So again, checking the blood sugar regularly, making sure that diabetes is well controlled is very important. And this is all what I mentioned earlier. So hydration is very important. Bone injection to be taken once a month or as directed by your doctor, and regular blood test, regular blood check, usual stuff. And this is so if you have any problems which are especially early morning signs, like constant pain in the bone without a reason, you have a fracture which should not have happened because you didn't, or feeling recurrent infections, or if you're feeling very tired out of reason, these are very common symptoms for all of us. So this could be a marker for anything. So it's not specific for myeloma, but it's very good, if you have such a problem, to go and see somebody, so that if there's anything, they can look into it. There's also an issue of increased awareness among doctors, because many times, all the symptoms are things that can happen in normal people, and even with people like, say, diabetes, for example. So the doctors have to realize that there's something else called myeloma which can be behind all this. So the doctors have to be more aware and think about things beyond common things like diabetes. Myeloma is not very common, but so that's what we have to work on doctors as well, to improve their awareness among general practitioners and other people. And this is one of the agenda of the myeloma network. We try to do doctor education and also education of ourselves and the patients. So anyway, all this has been not very positive. So just to show you how things have improved over many years, you can see that the blue bar is going up, which is quite overall response rate. You can see that the green bar is going up too, and you can see that it's going up steadily now, which is quite good. So the response is there, and you can see that these new medicines which are here, the R, all these things are newer medicines. And this were in trial 10 years ago, and previously you only got AAD, which is a very old therapy. So it's very important that the newer treatments are tried, and progress has been made based on all these newer treatments, and surely combined with chemotherapy. But the newer treatments have made the biggest impact in the way myeloma has been treated. Yes, so I think that comes from brings me last slide. So I would again like to thank all the motivated patients here who come, and also the nurses who have taken the initiative to come here. And over the last, I've been here with the forum from 2012, I think. Yes, that's the second meeting. And patients have been, you've been very forthcoming with your suggestions, etc. We think totally differently. Okay, I don't think about things like that. Okay, it's not in my agenda. So it's important to have a different perspective of myeloma, and that's what sort of resets my thinking process. So for me, at least, having this forum is a different way altogether. So that makes me think differently. And you've told us we need dietitians, physiotherapists, even artists coming and singing and dancing. So we try to bring them all here, and they all come with on their goodwill. So I think that's my only last slide to say that we must try to move on with even more of this and become a bigger event. Maybe next time we should have somebody who can speak, as Dr. Tan is mentioning, Mandarin or Malay. I clearly cannot do either, so I'll just stand and stop. But that's fine. Okay, that's my last slide. Thank you very much.